Dr. Holly, welcome to the Middle East,
Thank
Dubai in
you.
particular. I hear this is your first visit, so welcome on behalf of SV Companies. Thank you for joining us. So we always like to find out about your pathway in your veterinary career, how you started and how you ended up where you are today.
Okay. Like many vets, right? I grew up as a child wanting to be a veterinarian, so I knew at a young age I would like to work, I thought, with dogs and cats. So I studied towards that, even in my undergraduate degree. Went to veterinary school at the University of Georgia. When I finished my veterinary degree, I went into small animal practice, as I thought I would. But I found it, as a general practitioner, it was really, really challenging. Right, so many of us in the field, as you know, we're type A people, right? And we want to do the best at all of it. And it's really hard to be the best ophthalmologist in one room, and then the next room, the best neurologist, and then the best surgeon, right? It was hard. At University of Georgia, they have a really strong pathology program, so I'd had a lot of extra experience in pathology, and so I found that I gravitated towards the lab work and supported the hospital and the other doctors best that way with my sort of subspecialty, if you will. And when I decided to go back to specialize, I thought maybe I'd come back to that same practice, actually, as like a board-certified clinical pathologist, and I had my expertise. But it's easy to get caught up in academia, right? You get excited about the collaborations and the research that you get to do and teaching of the students and forming that next generation. So after my residency, I stayed on and did my PhD at Georgia. And stayed in a faculty position, but I still practiced on Saturday mornings at a local clinic because I still just really liked practice, right? And especially on a weekend morning, it felt like a community service a little bit even, right? Just connecting with the public and helping them around public health and keeping their homes happy and healthy, right? And keeping their pets healthy. So I really liked that balance. And then my family moved about a dozen years ago to Pennsylvania, and so I wondered what I would do as a board-certified clinical pathologist without a university setting. And I ended up just finding the largest practice in the area and joining. It was a general referral and emergency hospital, so unique to have that hybrid, at least unique in the United States, because of that caseload that comes in each of those scenarios, a lot of specimens for a clinical pathologist, right? So I joined that hospital as an on-staff clinical pathologist, and I thought I would also see patients. But it turned out I had enough to do, right, with first opinions, right, looking at lab work or looking at fine needle aspirates or effusions. Then the critical patients, right, the hospitalized patients that were there was our 24-hour ER service, and then our referrals, right, adding my expertise alongside other board-certified doctors, right, to solve some of the most challenging cases. So I stayed on in that position, really enjoying tying together, being that close to the patients, right, with contributing my expertise around diagnostics. And then I started doing I missed doing education, so I did a lot of continuing education for other veterinarians and nurses around maximizing diagnostic testing. And then I joined Antech 3 years ago. As their chief veterinary educator, so in an education role, still with a lot of outreach, right? So it's some internal education, but a lot of education for our customers and trying to help them learn how to maximize the testing, right? How they can get the most to help the patients. And I still consult the practice because that keeps me really...
Do you really?
Yeah, I do. Yeah,
Amazing.
It keeps me very close to the cases. So.
I would have loved to work in a practice where the clinical pathologist was just down the hallway. That would have been amazing.
Yes, and really actually right there in treatment, right? So not even to be that close really helped me hone my skills, right? To actually, in the university setting, for instance, and we're training other residents, right? When we would look at lab work, we would write up all the differentials, right? You could write a page and a half about a chemistry panel, right? It could be this, consider this, check this, test this, and then you'd pass it off and it would go back to the teaching hospital and they'd have other specialists and they would do the rest of the workup and I'd be detached from those results. And then in this practice setting, I would do a similar consult initially, and then they'd come back within an hour and, well, we checked this and we did this, now what? And I wasn't used to getting that feedback, right? But
it's a different pressure.
I know. It really
was
we're
still waiting and we don't know.
Yeah, I know. Yeah. And I said, I'm not used to hearing this. But because of getting that feedback, right, then I honed in those initial differentials, right, and getting close to the patient when they were getting the workup done, getting to put what the blood film looked like when I already saw what the ultrasound looked like and I heard the history firsthand, right? I just got a lot better at it. So
that's great. I always think with clinical pathologists, so what does clinical pathology actually mean? I always imagine someone in a dark room with a microscope and lots of machines, not someone who has their hands like actually on the animal all the time.
Yes.
So
people
you're
say
busting
that
some myths
all the
for
time.
me. Yeah, I have to admit.
People say all the time, shouldn't you be in the basement in a dark room? Yes, but
locked away.
I think it's a dream for a clinical pathologist, right? There's a reason I'm not an anatomic pathologist, right? I don't want the postmortem, right?
Yep.
I want to be part of the case, right, and making them better. And
So that is a different speciality.
it is,
Okay.
yes, correct. So while we do our residencies side by side, and we're still board certified by the same American College of Veterinary Pathology, we have 2 different tests and 2 different specializations. So
I see. Okay.
yeah, the anatomic pathologist will look at biopsies and histopathology and postmortem. Sometimes they'll augment it with virology or microbiology, but again, in the postmortem sample. And then our specialty will be from the living patient, generally, right?
Yeah.
So we're looking at the lab work and the aspirates. And I think many people probably use the clinical pathologist most to look at microscopically at fine needle aspirates, is what maybe most people think. But in this practice setting, I had far more cases where I was consulting on the lab work, right?
Okay.
Than those. Every sick patient needs some help on the lab work, right? And so that's probably 80% of what I did, with like 20% looking at this cytologic specimen.
I have a question that I'm a bit curious about. So from the moment that you graduated as a new, recently qualified vet, I don't know if we still call it minimum database. That's what I would have called
Yes.
it when I graduated. Like, what's the minimum? If there are financial constraints and if there are reasons why you can't run a full panel, what would you do? Has that minimum database changed that you would have run when you graduated versus the vet that you are now? If you're in the same situation, still those constraints, what's your minimum database looking like now?
So I still think we lead saying CBC chemistry urinalysis, right? So the same thing that I was taught as a student, but now we have access to higher end technology to get a lot more information from each of those, right? And then they more quickly lead to the more advanced diagnostics, right? So a lot of people, and depending on the case, part of that minimum database may be the imaging. While it used to just be radiographs, it's now often a more detailed ultrasound. Right? So depending on what the presentation is and what you have access to at your practice, right? But depending on the patient, and we're really conscientious about trying to practice across the spectrum of care, right? And so it's really important. I think we have really changed our mentality, at least in the United States, to no longer be the person in the room as a veterinarian who says this is how it should be done, right?
Yeah.
And expect an owner to have understanding and finances and compliance, right, when it's not necessarily their values or their wishes, right, for their pet or their opportunities. So now I think we do a much better job of learning what's most important to them, why they've shown up for that appointment, and meet them where they are at. And so sometimes if there's a financial constraint, we'll be resourceful, right? Maybe it's just a drop of blood to look at a blood film. Maybe it's not a full CBC, right? And sometimes maybe we're more reliant on our palpation skills because we can't get to imaging, right? So I think it's still the same perspective on a minimum database, and I think we have just more opportunities now to bring expertise close to the patients.
Amazing. On that note, do you think that vets in general need to get better at reading blood films and blood smears?
Well, as
Thinking of my own shortcomings here.
yeah. Well, you and everybody, but I think that we've been telling people that we should look at a blood film with every single CBC, right?
I know.
But guess what? We've been saying it for over 20 years, and it still isn't happening any more than it was before. So what we've done now is, and I can say this as part of being on the diagnostic side of things in industry, is bringing advanced technology so we can circumvent that lack of commitment to the blood film, right? So now there's
Most vets
imaging.
are time poor, aren't they?
Yes.
So it's hard.
It's hard, right.
And until you get good at it, it takes a while,
Yes, and it's all levels of it. It has to be a well-prepared blood film to
Yes.
be useful. It has to be a well-stained blood film. You have
Yep.
to have a nice microscope, right? There's so many obstructions, right, to getting the quality
the shaking
review.
that my hand does when I go to, and
the
it's
whole
fine the rest
thing.
of the time, but if I'm trying to make a blood smear, it's a
Oh,
disaster.
yeah, or if someone's watching.
Yes,
Yeah.
if someone's watching, it's even worse. Yeah, awful.
So now there's, we, when I speak about hematology, especially around in-house diagnostics, I'll talk a lot about the cytograms that are generated generated by these analyzers. So there's actual graphical depictions of the cell populations that can actually be a lot more sensitive in detecting pathologic changes than even myself at a microscope looking at a blood film. So I think it has changed how the information we can get from the cells, and we now focus blood films towards certain things that we're seeing on the blood work itself from the automated analyzers, or again, we're using some advanced analyzers that actually look at morphology of cells as well.
What area of diagnostics then do you feel are underutilized in first opinion practice when you're going out and educating as an outreach program? Probably.
It would be around hematology again.
I thought it might be.
Yes, because I think that, and it's something I certainly appreciate more and more, having been that close to the patients, right, as a clinical pathologist, and realizing that the whole numbers don't tell the whole story, right? And it's really interesting. We think about when we sample blood and we look at the blood cells, we are capturing them a moment in time, right? That is, they're in transit from a tissue demand and the marrow meeting that demand, right? And it changes by the minute, certainly by the hour, and certainly by the day, right, for every patient. And so we have very wide reference intervals, which means they're insensitive to detecting abnormalities unless you watch it really closely. So I think that it's very underutilized, the advanced technology, because we're not trained towards it at school. We're trained towards those whole numbers. I don't think they describe the whole situation.
No, and I do think that the technology's moved so rapidly. I've been graduated over 15 years now, and it looks completely different to how it did when I graduated. So there's no chance to go back to college and be like, what I learned doesn't match what I'm seeing in practice, so I need some help. So it's definitely an area where vets feel possibly that the rug's been pulled out from under them a little bit, and where's the opportunity to learn? Where's the opportunity to kind of sit down and take the time to really find out how these machines work and what they can tell you?
Yeah, and there's a disconnect too, right? Because in the university setting, they don't generally use the point of care analyzers,
Not
right?
the same ones that you have in first opinion.
Right, so they generally have a reference lab there in the teaching hospital. And so we don't give our students and our developing veterinarians enough experience to learn those, right, in an academic setting. And so what happens is, it's not just that you graduated 15 years ago, right? It's that they're still not really learning it today, and then they get into practice, and really what they end up learning about the analyzers comes from just when the salesperson stopped by, right? So unfortunately, it's not built into our education really well, which means I have a job for a while, right?
I think you do. Yeah, I definitely think you do. And not just with the technology itself moving forward, but the actual parameters that we measure now are very different. So certainly CCRP and SAA, the inflammatory serum markers, were not something that I used routinely. Do you find that that's, again, an area where it's difficult for vets and vet nurses to catch up, basically?
Yes. We're still, it's really hard to make up ground, right? And so if you don't graduate having learned about it, having seen it in application, and if you join a practice, right? You join a practice and you adopt the mentality often of the practice that you join, right? So I
and what they use regularly.
Yes, when I can connect with an audience and we talk about acute phase proteins in particular, and I go through multiple cases, I see how excited and engaged they are, and I know I make a difference for that group in the room, right? But it's such a small percentage of those out in practice, so I think we still have a lot of ground to make up.
Do you think that those tests are then underutilized or misused?
Underutilized.
Okay.
Yeah, I think very dramatically underutilized. And the power, especially in looking at acute phase proteins, is also in trending them. So it's not just in running it once, right? And that might be where it's maybe not misused, readings. But beyond once, the power in once is recognizing that inflammation, right? Yeah. But once you have a number on it, that's the beauty, right, of these acute phase proteins, is that it's not the subjectivity of there are bands on the film, right? Or there's some toxic change, but you actually get a number on it, which means tomorrow you can check again, right? And the next day you can check again.
More of a prognostic indicator, where you can see how your patient is recovering. Yes. How would you advise veterinary? This is a very difficult question, I think. How do you advise veterinary professionals when financial constraints make in-house diagnostics challenging? Or how do you help them justify the prioritizing that for their clients?
Well, so as you've heard, I really lean towards hematology, right, as a first starting place, and we can do it really affordably, right? So we can start with just a PCV and total solids and maybe a drop of blood for a blood film, right? So we can be really economic about our approach. But I think if we can start with recognizing an anemia or inflammation or confirm a thrombocytopenia, and we can do that in-house, right? So we have the owner there with us, right? The pet owner's there. And so you bring them along that diagnostic journey, right? It's a minimal commitment to get those first few parameters, right? Financially and time-wise.
Yeah, of course.
So then if they're still there, right, then you get to show the value of what you have found, right? So I think we are more successful in running more diagnostics when we do them in the practice setting because the owner is right there with you, and then you get a chance to show them that value. I think what happens if we send off our lab work, right, is that when we get back the results, we are limited in our communication, right, about that because we pick up the phone and we call, right? We hope to get the same person who was at the appointment yesterday, right? And no one has time, right? And so, and probably what's even worse is when we say like the CBC and chemistry are normal, as if there were just 2 tests you ran and there's 2 normal values, right? Which then they wonder probably why they spent so much money for that, right? But if they're right there with you, especially if you can even just run a CBC, it's not one test, right? So we're gonna have 25 different parameters. You show them what we learned about the red cells, what we're able to rule in or rule out with the white blood cell patterns or morphology. Same with the platelets or any infectious agents. And when you've taken them through that, you've really shown them the value of what you've done, right? And then once we recognize inflammation or a concern about tissue destruction or immune reactivity, red cell disruption, it warrants the next step, right? So we've identified one problem. Now, how are the organs affected? Right? So we bring them on that diagnostic journey where they can then make the choice to find out from a chemistry panel, right? Or to go towards imaging, et cetera.
I think it also helps if you have really concerned owners as well to be able to start that pathway immediately and give them some answers. I used to hate to think of people sitting at home waiting for the phone to ring if they're really, really concerned and they're waiting on that result.
Yeah.
It can cause a lot of stress.
And I think it's stressful for the veterinarian as well, right? Because they've had a sick patient come in. They've had to make their best guess at what's going on. They come up with something empirical for treatment, right? And now 24 hours later, they might find out, I mean, we've all had those sleepless nights, right? Worrying about that patient where we don't have an answer for them. And then the next day when we call the owner, sometimes we have to do a 180, right? On what we thought we were doing. Actually, don't take that medication. Can you come back in? We need to do something else. It's clunky, right? It's not as easy in the workup for that patient. They don't get the help they need as quickly.
No, perfect. Something that we see here very commonly in human medicine is wellness screening, but it hasn't really translated into veterinary medicine as yet. And I think I would always have been, rightly or wrongly, of the population that thought a little bit, why am I looking for something in an overtly healthy patient? Like, that's very, very difficult to justify to owners that there's, the reasons behind doing this. What are your thoughts on wellness screening in our pets?
Yeah, obviously a big fan, right? I'm a big fan of data. So I think there's a couple different avenues that we can explore when talking to the pet owner, right? And one is the studies will tell us, right, that a significant number of dogs and cats who appear clinically healthy, right, will have abnormalities in their lab work, right? So we know that we're uncovering disease earlier. We know that early intervention for kidney disease, right, will make a difference in their quality of life, right? We know that we can prolong their lives if we detect things sooner. So I think if we maybe show them some of the actual studies, some of the data that lets us know that we're missing things, right, if we don't look. But I will say from a data standpoint, even more so, getting baseline data truly of health, right, really helps us then more sensitively detect change as they age, right? So I actually want to know what normal looks like, and I want to celebrate that normal, right? I don't want them to be disappointed that we didn't find an abnormality, right? If we look at a CBC in chemistry, I want to celebrate how good everything looks. But if we talk, and I'll in my presentation tonight, I will speak about this, but how we establish reference intervals, right? When we're looking at hundreds of dogs or hundreds of cats or whatever species we're looking at, they're deemed clinically healthy, right? But we're taking everything from a teacup poodle right through a Great Dane. I mean, they're really almost different species, right? So inherently, even if you take the centralized population, right, of these distributed parameters, they will be inherently wide, which means they're very insensitive for an individual pet, right, in detecting a change. So I'll use kidney disease again, and we think about creatinine, right?
Okay, that's what I was thinking of.
Watching a rising creatinine, right, you can detect kidney disease months or years earlier, right, than if you just wait until it flags high and goes outside the reference interval. So we want to double down on that value when we explain to them, like, we'd really like to know what normal is. And when we look next year, right, these are the parameters we're going to be particularly concerned about, right, and what we're going to be watching, so that if we see this change, once we've established a much more narrow reference value for this particular pet, right, the real value is going to come when you repeat it next year and the following year, right? And in our guidelines from the American Animal Hospital Association, they actually are recommending as pets get into their senior years every 6 to 12 months. So even twice a year.
To screen that frequently?
Yes, okay. Right, because we're seeing changes, right?
From what sort of age?
Yeah, so they will say generally 7 and older.
Okay.
Yeah, I think for both dogs and cats.
Okay, for all sizes of dogs, would they start earlier perhaps with your larger breeds? Or?
You would imagine, yeah. I think it's hard to give exact guidelines for every single age, and size. But yes, as we would know, right, as a large breed dog, right, will become a geriatric animal a lot earlier.
Earlier, yeah. How do you feel about the sort of new technology in cancer screening? Because I can see that we're going to start profiling our pets not only on their age, but potentially certain breeds that we know are predisposed to certain conditions. How far along the journey are we with that?
Yeah, so I think that we are really still on the cusp of it, right? I think it's putting together a bunch of different tools, right? Because we have genetic tools that even tell us about predisposition, as we talk about, right? We're already breed profiling them, but genetically we can find out really what they're predisposed to, right, in development. But then I also think we have biomarkers that we can look at. Nucleosomes is one of the tests that we can run. We can look for these biomarkers to say there's increased cell turnover, right, that we have concern for a neoplastic population. But again, as a hematologist by my passion, I will tell you it's really unusual that we could have some systemic cancer and not see some changes on the CBC. Okay. Again, maybe not in the whole numbers, right, but in red cell changes where they're getting disrupted, or a stress leukogram, or some subtle activated monocytes from tissue turnover, tissue destruction. So we're really pulling together, I think, resources from a bunch of different places. And I would include imaging in that as well, right? If we're talking about cancer screening, I can tell you that if I had a breed that commonly gets hemangiosarcoma, like a golden retriever or a German shepherd, I would be ultrasounding their abdomen and their spleen every year after probably age 3, I would think, right? So I think there's a lot of different cancer screening tools that we can use collectively.
Okay, brilliant. What 3 tips would you want to leave veterinary professionals with who want to optimize outcomes in their in-house diagnostic use beyond what they're already doing? Where would you start? Yeah,
so one is I would leverage the technology, right? And again, I'll start with hematology because that's the biggest change, right? That's in the field that I don't think people are familiar with, is understanding the technology of their hematology analyzer so they can maximize the data that they're getting, and in particular around those cytograms, right? Yep. It's giving us objective evaluation of the cells, of tens of thousands of cells, right? Very sensitively detecting abnormalities. So learning the technology of their in-house hematology analyzer, learning what normal looks like, getting familiar with those patterns, empowering our nurses, right, who are in the lab, because they'll actually do it better, right, as you know.
Yes,
right?
They will.
Yes, give a nurse a job 100%. To do, right, and they will do it even better. And
yep.
So having them learn the patterns, right, and calling that attention to the veterinarian as they hand over that lab work, to say, before you even look at the numbers, I'm concerned about this particular population, this cloud of cells here, or this change that we're seeing. So that's one thing I think that would really be rewarding if they'd start now, start to learn normal, start to recognize just that the abnormal versus normal even, right, would be just a great start. And then they'd start to learn those abnormal patterns once they saw that patient through their diagnostics, right? And so that would be one of my tips, is to learn the technology, right, that you already have, right, so you can leverage that. I do think an advantage of running the in-house diagnostics, as I mentioned, was reviewing the results with owners. Right, and I think that has done a lot in our practice for us to build relationships, right, to build trust, right? So we're not just taking their animal on the back, getting some blood and coming back, a certain amount of time later and saying it's X, Y, or Z. We're actually bringing the results to them, right, reviewing them with them in person, telling them I see this, and so I'm concerned about this, and you're circling areas on the lab work, right? You're showing them results, and you're really showing them the value that really of what they just spent their money on or committed to spend on. And then when you show them the concern and say why you'd want to do the imaging or the follow-up or a certain treatment, usually they're on board with you. And I think it opens up a lot of doors to move a little more quickly right through the rest of the treatment plan or diagnostics that you need to do. So that would be my second tip, would be reviewing those. And then my third really would start to be establishing some of those wellness data points.
Okay.
Right? Is really if starting even with your own staff, right? Even with your own staff to establish normal for their pets, right? So they could see a change, right? So they can find out what they were missing. And then when they're talking to pet owners about this, it's authentically sharing their story, right? If I hadn't done this, I wouldn't have known X, Y, Z. Beyond the CBC and chemistry and urinalysis and detecting abnormalities or resetting, a reference value for that pet, I think our screening for infectious disease as part of our wellness is so important too, right? So we are informing about risk for that patient, right? It doesn't mean they're sick with something because they have antibodies, right? But it does mean that they've been exposed, that in the US and Pennsylvania, we have so many ticks, right? So we see so much tick-borne disease, and it lets us know anytime we see increased antibodies, right, that we've had exposure, right, that there's been a breach in whatever our tick control or preventative methods are, right? So that's always worth a conversation, and then we know how much it affects human health, right? There are studies that say, right, that in areas where the antibody levels, are high in a certain percentage of dogs, that people are at increased risk as well, right? And so I think we're doing our One Health obligation there as well.
So would you do that at the time of vaccination, like at a routine check? You do that advise that every year?
Yes, and I'm glad that you say that because, right, for our vector-borne disease screening, I feel really strongly that it's something that we should do during health. And the reason why is that it's very challenging on those antibodies in a sick dog or cat or whatever species we're looking at. When we look at antibodies, it doesn't mean they have active infection. And it can cloud that picture when they're actually sick.
Yeah.
So it's best when they are healthy to screen for exposure, to inform us about our preventive care protocols, what we're at risk for, right? And especially around, then something like fecal testing, right? If they're asymptomatic but catching something that could even be zoonotic to the family, right, would be, again, checking that One Health box. That's so important.
When you're looking at the fecal screening, would it be useful, because I know there is a test I did on Audrey, actually, the key screen, to have a look and see whether there is any resistance to the deworming protocol that we've been doing.
Right.
That's not something that's commonplace, definitely not in our region, I don't think.
Well, I hope that it will be, because the key screen is a PCR test, right? So it's a GI parasite PCR. And when this test came out, it gave me pause and reflected on the fact that I am shocked that we still have been macerating fecal samples and floating ova, right, that only shed from a subset of the GI parasites, right, very intermittently and very insensitively, that we've been doing that same diagnostic test the same way for generations, right? Nothing has stayed the same in veterinary diagnostics, but why we were still doing that until we finally brought PCR into that space. And now we can screen for so many different GI parasites, right? Beyond just nematodes that shed ova, right? But then we have genetic insights, right? So now that we have the molecular material, we can look for treatment resistance for hookworms, right? Something that is zoonotic, right? We can also, it really helps us inform us around our antimicrobial stewardship, because for Giardia, like, we can see if they have the zoonotic strains or not. So in an asymptomatic pet, right, that has a non-zoonotic strain of Giardia, maybe we don't treat, right? And so I think we're really advancing our medicine and how we're effectively treating these pets, or staying true to our antimicrobial stewardship by using these more advanced diagnostics.
I do think that's going to make a huge difference when you meet a lot of our veterinary professionals later on. I think Giardia might come up a few times. It's definitely a seasonal challenge that we have been facing for a long, long time. Dr. Holly, can you give us an example or a case study of a case or a disease process that is easier to detect and easier to manage since the technology has improved and progressed?
So very impactful at our practice, right? I'll recount one story. We had one of our technicians, so her own cat that she had bought from a breeder. So she bought this cat from a breeder. She brought it right to the hospital, right from the breeder. It was a Bengal cat, a male intact Bengal cat. She left him at the hospital for the night to be neutered. Normal physical exam. Breeder had reported no problems. No problems with anesthesia or his neuter. Upon waking, he had some diarrhea. She thought, well, I'll leave him at the hospital for the night, probably some stress colitis. But the next day, the diarrhea progressed, even in the hospital setting. And so we probably have this experience here as well. But it used to be pretty reflex that we would give metronidazole, right? We'd reach right for an antibiotic, unfortunately. Like we do know better
Especially
now.
with that history from a breeder.
Yes. So she treated with metronidazole. She brought that home. Well, the diarrhea progressed in the face of being on metronidazole, and he became a really cranky cat. Right, it was really uncomfortable, obviously, for him and their relationship. Right, in these early weeks at home, she brought him back in. They did fecal testing. There were no ovocine. They looked for Giardia. They didn't see any on a direct, and she ultimately had an ultrasound done. And on ultrasound, it showed a thickened wall of the colon and concern for IBD. And so inflammatory bowel disease. And so the clinician was recommending maybe starting on some Tylosin, considering some prednisone, a diet change. And she was reluctant after having done a whole course of metronidazole to switch to like a different antibiotic, right, a second antibiotic, and he wouldn't eat the prescription diet that they had recommended. So she tried some other supplements at home. She had tried a probiotic. She tried increasing the fiber in his diet, but things would work for a little limited success, and then it would return. And then he was going to the litter box multiple times a day. She was having to bathe him, and he's a Bengal. He's super sweet and cuddly until you're trying to manage him in a place
be my
he
favorite
didn't.
job.
No, it was wrestling like a wild cat. Yeah. Brought him back in, and on ultrasound, still progression, right, of the thickening of the bowel wall. Fecal exam on a flotation was negative again, and said, I guess maybe he does have IBD, and I'll have to start some injections, some vitamin B injections, some Tylosin, as well as steroids. And we had the new test became available to the key screen. So the GI parasite PCR panel had just become available. And one of the technicians in the lab, because again, the technicians make or break a test, right, had said, hey, do you want to try? We have this new test out as an option. It should, look for more GI parasites, and we're finding on typical fecal flotation. It does it much more sensitively. That's at least what I've heard, she shared. And so she said, I'm willing to do anything because we don't have a quality of life together, right, her and this cat. And they sent off key screen, and it came back as tritrichomonas. And we had never diagnosed that in our practice, right? So the practice for 25 years, right? We see cats with diarrhea, and we diagnose a lot of inflammatory bowel disease based on very similar clinical presentation like he had and with the imaging findings. And finally getting him on the right drug, the ranitazole, right? Getting him on the right drug at the right time for the right bug, and his diarrhea, which had been intermittent for months, right, cleared up within days, and certainly by the end of the protocol, right? It quite literally saved his life, right, getting that right diagnosis. And to think that at our hospital, we never had made the diagnosis because we never had requested a culture for it or a specific smear looking for it. And since then, we've had more than a handful of similar cases come through our hospital. So it's been really impactful, right, very personally, right, within our hospital, but then what we're able to offer to our clients as well.
Amazing. And it's very reasonably price point, I find, the key screen. And of course, it's not just looking for one infectious agent, it's looking for a whole list. So
yes, and once we have the technology with PCR, right, we can adjust that panel, right, as we find out more genetic information, because we can look for treatment resistance, right, so we can understand there's antiparasiticides that are no longer effective. We can alter some of those protocols. We can look for the genes that confer that resistance, right? We can look for, in Giardia, we can look for the zoonotic strains versus those that are not known to be zoonotic, right? To help us decide which of those actually need treatment, right? So it can help guide a lot of our therapy.
As well. That's incredible. Thank you.
Thank you.
Just to wrap up, Dr. Holly, we always ask what pets you have at home. Because we're curious and we want to know.
A menagerie. So I have a bird dog, right? So her name is Willow. She's a Llewellyn setter, so a type of English setter. At our practice, we have a lot of hunters in central Pennsylvania and a lot of grouse hunting. And so a lot of these bird dogs, when they fail out, they come to our hospital and get adopted out. So
amazing.
Yes, she's a failure bird dog and a very, very sweet pet. So we have Willow, we have a cat, Brian Scalabrini is his name. I'm shocked he's still with us. So
amazing.
He is 18 and a half. He'll be, wow. 18 and a half. He is down to 3 legs. He no longer has his thyroid. He has heart disease. He's, like owned by a veterinarian, right? He's amazing.
He's in bits and pieces.
He's in bits and pieces, that's right. But just very happy.
Yeah.
We have a bearded dragon. That was a COVID birthday present for one of my boys. Yep.
Lovely.
So we have a bearded dragon in the home, and then we have 3 chickens outside.
Amazing. And can I be nosy and ask what your husband does? Because you did give me a clue earlier.
Yeah.
And I think it's fantastic. Not that you're not cool,
but
he is seriously
he's
cool.
a little cooler. Yeah, so he is a wildlife veterinarian.
Okay.
So really interestingly, we met both during our PhDs in pathology, even though we couldn't do things more differently now, right? Okay. So he really, he's had 2 roles, and one is being a diagnostician for wildlife. So a lot of infectious diseases that they're screening for, right? And it's really different in the wildlife world because they'll actually sacrifice the animal, right? To understand what's going on with the herds, right? When they're sampling them. But then he also, when he was a state wildlife vet for Pennsylvania for a bunch of years, that's what brought us up to Pennsylvania. They do a lot of health screening, right, for the wildlife of Pennsylvania. And it's a wild state. So I did not realize we have a lot of black bear. We have elk that were reintroduced to the state who have been thriving. So super cool to see elk. And then we have right, there's not a lot of wildlife here in the city.
Not so much, no.
But we have everything, right? So we have the skunk, we have the porcupine, we have the gophers, we have badgers, it goes on and on and on and on. Bats, that's something that he's worked on, interestingly, and he does a lot of research on influenza, in wild birds. So then there's like a whole bird stuff that he looks at. So really a diversity of animals.
Does he ever have to bring patients home?
We have had a baby bear in our bathroom one night, which is pretty special. Yeah,
that is seriously cool.
But many of the animals that he helps the population, and we don't get too many live animals home.
Okay, all right. I will keep the baby bear in the bathtub in the back of my mind. I think that's fantastic. Thank you so much for your time today, Dr. Holly, and we're looking forward to the rest of the weekend and all the activities that we've got and the events that we've got planned to get you out in our veterinary community. So thank you so much for making the journey all the way over here.
Yes, my pleasure. Thank you.